traumatic brain injury. Now, we won't discuss because there are different ways you can sustain head trauma. It could be in sports, it could be um, violence related to crime. It could be an accident, for instance, vehicle, say, or vehicle to vehicle, or pedestrian against a vehicle, or pedestrian against pedestrian, right? And then we have the um, e-scooters now. Okay, they're also just as fast as any or faster than bicycles, in fact. Okay, so be careful out there. So head injuries, there are 3 levels of head injury. Head injury, that's traumatic brain injury. So we have mild, severe, moderate, and severe. For mild and moderate, they have the greatest chance of survival, of course. Severe head injury, those patients usually die after 48 hours. Right? They may live for up to 48 hours, but most of them die. Mild TBI is also called a concussion. Okay, that's the layman term. Prevention, I won't read all of them for you, but for those of you who do ride bikes or e-bikes or motorcycles, what do you always wear? Okay, please wear your helmets. Can't imagine really these people riding those e-scooters without helmets. They're just asking for trouble. I mean, those things are fast. Okay? You can hit your head just walking. How much more if you're traveling 30 miles per hour? As already started earlier, so the primary injury is the consequence of the direct contact to the head with any force, either blunt force or penetrating force trauma, for instance. So those are, we're talking about the contusion. Contusion is the injury to actual brain tissue. Now, contusions can be coup contra coup, meaning, yes, you hit your head here, for instance, so there's injury to the frontal lobe. However, depending on the level of force applied, so if the force is quite great, if quite high, then the brain can ricochet from the front and then hit the back of the skull. So now you have 2 injuries, right? You have a coup contra coup injury. That will also include lacerations, hematomas, or skull fractures. Okay, so these are all as a result of the brain injury. Okay, so these are all called primary injury. So it will show up on the CAT scan or an MRI. Oh, you have sustained a contusion, or there's a hematoma, etc. There's a fracture. These are all the primary injuries. Again, we talked about there will be up to six secondary injuries though that will follow. Okay, so the patient's problems are just beginning. So these are now the second injuries. So this will ensue over the next hours up to 2 days after the primary injury. Most of them are caused by increased ICP. So increased ICP can snowball to the other problems. So they are increased ICP, the hemorrhage, the edema, intracranial hypertension, hyperemia, seizures, and vasospasm. So 3 were already mentioned earlier under the hemorrhagic stroke. And these are, again, other effects once you have increased ICP, which will further increase ICP. So they are hypotension, hyperthermia or fever, hypoxia, hypercarbia, infection, which will most likely be meningitis, especially if you have open head injuries, because now bacteria passes through the open skull, okay, and then enters the brain. And then anemia. So here's the Monro-Kelly doctrine or hypothesis. Simply put again, think of the glass of water we talked about last week. So all it says is if one of the 3 components increase in volume, at least one of the other 2 must decrease in volume. Okay, they have to be displaced. That's just the natural order of things. You increase it, well, you have to displace something else. Okay, and what is that thing that is always displaced? the brainstem, unfortunately, because most increases in ICP cannot be simply displaced or accounted for by simply displacing CSF. CSF is only 10% of the total cranial volume. Plus, it's not located right at the base. It's more of them are in the ventricles at the center of the brain, so it can't be easily displaced. Again, this doctrine only applies to what? A closed head injury. It doesn't apply if your skull was blown away with a shotgun. Of course, there's no increased ICP because the brain is free to swell everywhere. Okay, so the brain is now here, so there is no increased ICP. Okay, let's start with the minor. So we got scalp injuries. The scalp is actually very vascular. I found out the hard way because I played hooky. Actually, we went to a school that wasn't our school. Okay, so we played hooky for my school, but then we trespassed into the public school. And I thought I was smart ass. So there was a barbed wire. So my friend uh, put his foot on the lower barbed wire, and then he raised one like this so we could all go through, right? But I underestimated it. I didn't duck too low, so I still hit the barbed wire. That ow! I just said this, and then hey, come on, let's go. But then when I looked at my buddies, they all stopped and then turned pale, and they started sweating. And I said, "What's wrong with you guys?" And said, "No, nothing's wrong with us. It's you, because I was bleeding. My face was filled with, I thought it was sweat. I was covered in blood. So scalp actually bleeds profusely. And I was running home and I thought I would get sympathy from my mom. So what are you doing here? You're supposed to be in school. And I was covered in blood. But she figured that was okay because I was talking. So as I was cleaning myself up, I was getting a whoop ass. Then we got skull fractures. Skull fractures can range in severity. Oh, by the way, the Monroe-Kelly doctrine also doesn't apply in an infant. So if you're less than a year old, of course, the sutures are open, the fontanelles are open, so it doesn't apply to an infant either. I'm not testing the fractures. However, there are a few signs here that we know that there is a fracture. One is raccoon eyes. So you've seen anyone's 65 or older that look like they got black eyes. Actually, it's not a black eye. That means there's a skull fracture. Okay, and then the blood of course seeps out of the skull and then it has nowhere to go. It usually settles in the periorbital region. And if it's a basal skull fracture right here, of course, it usually appears as a battle sign. So there'll be bruising, heavy bruising behind the ear. Okay, so that means the lower skull is fractured. So when these people fall in the nursing home, so you'd think when they show up in the hospital, you'd think, oh, what did the other guy look like? You think like they were fighting, but that's a skull fracture. Okay, when you see raccoon eyes. Yeah, and then of course they get worse over the next few days because of course they will turn color, right? So they'll turn black, and then as it heals, they'll turn green, etc. So here's the battle sign. Okay. Now for any liquid again coming out of the nose or ears, how do we know that it's CSF? Okay, the halo. How do you elicit the halo sign again? You dab the bloody drainage with gauze, okay, and then what we expect to see? A yellow ring around the blood. Statistics wise, it's actually the elderly that suffer head injuries. It's less likely in young people, although young people are more daring, right? but most TBI statistics actually happen in 65 years or older. Most of them result from falls or from accidents, car accidents, I mean. If it's a non-depressed skull fracture, meaning it won't affect brain tissue, then no surgical treatment. But for those that do, especially there are signs of uncontrolled increased ICP, then there has to be craniotomy. All right. So for TBI, traumatic brain injury, again, there is mild, moderate, and severe. So here's mild contusion or concussion. There's bleeding. Now, regardless of which layer of the dura the bleeding is at, say it's subarachnoid or subdural, epidural, for instance, doesn't really matter because any hematoma, are they space occupying lesions inside the skull? Will they increase ICP? Yes, of course, some hematomas will increase ICP faster than others. That's the only difference. But any hematoma is a space occupying lesion, unless the hematoma is just under the scalp, right? So meaning outside the skull. But if it's a hematoma underneath the skull, all of them will occupy space and therefore increase intracranial pressure. So I won't go into each type of hematoma. So this is what I'm trying to say. So these are different hematomas found in different layers inside the skull. So regardless, will they occupy space? Will they displace the poor brainstem? Yes. And look at again these parts here, these are your ventricles right here. They're not supposed to look like that. So whenever you have brain displacement, either lateral displacement or downward or a combination of both, you have downward and lateral displacement, they will obstruct CSF flow. So increasing ICP levels and then increasing ICP. Signs of brain herniation are the following. So the level of consciousness will change. It will deteriorate. So this is where your Glasgow Coma Scale scoring skills come in handy. And your pupillary changes as well. So dilation of the pupil or fixation, meaning they do not respond to the pen light anymore. Uncle is also called a downward herniation, which of course pushes the brainstem out of your skull. I won't cover brain tumors because really, if you think about it, a brain tumor, will it be any different as this? It's exactly the same, right? So I won't repeat it. So the last section of this chapter will cover brain tumors. We won't cover that because it's really the same effect. Of course, the treatment, is it the same? No, in treatment would be under cancer, which is either chemo, radiation, or surgery. Okay.
So one of the will cause more
Of course, it'll be the intracerebral. Okay, let's go to management. So first up is, of course, we have to diagnose it. So a CAT scan or MRI Doctor will decide. CAT scan is always the first option because it's the cheaper option. And if we can't get the proper picture, or let's say depending on the radiologist's recommendation, okay, so if they see something and then they're not sure what it is, then they'll always say, we recommend an MRI. By the way, because we'll do spinal cord injury next week, for every head injury, we also assume that there is spinal cord injury unless we can rule it out already. Okay, and then vice versa, always goes the same way, because where is your skull? Sitting on top of your spine. Okay, so vice versa. Okay, so again, until you can rule the other out, we assume there is head and spinal cord injury. Okay, let's repeat ICP. So we already had the bullets mentioned under the acute ischemic stroke section. So first, of course, is what are our options again? To treat increased ICP? Okay. Okay, so let's review. Since CPP is mentioned here, what is the formula for CPP again? MAP minus ICP. Okay. And why is it like that? Okay, so we have MAP, you know the formula for MAP, right? Okay, and what is the CPP supposed to be? 70 to 110. Okay, technically, again, at 60 CPP, the brain tissues are alive. Do you want your CPP to be at 60? Why? Because once it drops below 60, brain cells die. So you want to be over the edge. You're playing always 60, okay? No, because the slightest drop in your blood pressure will result in brain death. Okay. So let's review again. The interventions are oxygenation. Okay, so adequate oxygenation to achieve this usually, because once we have brain herniation, respiratory rate drops, right? So we have to intubate, correct? And then the patient receives good oxygenation, and then we make sure the CO2 remains normal. Elevate, what's the degree again? 30. Okay. Normal blood volume, so the patient will receive IV fluids to maintain blood pressure. Now, in the first place, we need an invasive, because we know how to calculate MAP. How do we measure ICP? It cannot be measured unless you put a invasive device in there. Now, there are different options. We have bolts, screws, but the most frequently used invasive measuring device is the IVC, intraventricular catheter, IVC. The beauty of a intraventricular catheter, the name itself is, where is this placed? In the ventricle of the brain. So either the left or right ventricle. The beauty of the IVC catheter is it not only measures ICP, you can actually drain CSF to help lower ICP. Okay, whereas the other measures only measure ICP, they have no ability to lower it. Okay, so at least the intraventricular catheter is both diagnostic and also therapeutic. So these are the other supports. We already talked about intubating the patient and put them on a ventilator to maintain oxygenation. Seizure prevention, again, the doctor won't wait for a seizure. They will institute in order anti-seizure. So it's usually Keppra, which is levetiracetam, either Q12 or Q8 hours. electrolyte because these patients are in NPO. So we'll have to have a feeding tube. Unless the ICP is really high, we usually use NG, okay, nasogastric feeding tube, because this is short term, right? It's only, we don't expect the patient to be forever having the feeding tube. So it'll be nasogastric tube. If the ICP is too high, then we lower it first before inserting the tube because the insertion will increase ICP as well. The insertion, NG insertion procedure. Okay, I already mentioned the use of anti-seizure medications. If they do have a seizure, what are the two drugs approved to stop it? Lorazepam or midazolam, or it could also be diazepam. If the patient is intubated, they'll be on propofol. So we keep them sedated. Okay, so sedation, either using this a benzo, or you can also use barbiturates. Okay, so the purpose of inducing a coma is to decrease metabolic demands of the brain. Okay, so we want to arrest the brain. We don't want to overwork the brain, so just induce a coma. So this is the option for moderate to severe TBI. Barbiturates, phenobarbital. Now, this nasogastric tube is not really the feeding tube. Okay, this is this is not used for feeding. This is used to decompress the stomach, okay, if needed. Actually, this will prevent vomiting because there is no peristalsis, right? So all the gas and acid will come out this way. If they can't come out the other end, it will come up as vomiting. Now, we don't want these patients vomiting. If they vomit, they will die, okay? Not just aspiration. The ICP will increase, and then your CPP will drop. We won't discuss brain depth. We're not really involved in pronouncing brain depth, but just be aware that you will be called. You're the nurse. You will be called by OPO. What is OPO? Organ Procurement Office. So for New York City, there is a Live On New York. That's what we call our OPO here. There's an office in every major hospital. Okay, so if it's a big enough hospital, not a clinic, there's an OPO there. They have a representative. Of course, business hours, off hours, there's a hotline you have to call. Okay. And if this patient has been in the ICU for several hours, they will call you constantly because each patient is a potential organ donor, right? So therefore, patient has likely low percentage of survival, they will contact you. So and of course they don't know what you're doing. It's a phone call, so don't take it personally, okay? So don't shout at them saying, I'm busy, okay? It's just a phone call, okay? So you can just tell, okay, I'll call you. I'm busy right now. I'll call you back. Are we clear? Now this is important, okay? So organ procurement is important. I want to make sure everybody understands this. All right. It's not like they're praying for this patient to die, okay? But they don't want to lose viable organs either. You understand? Okay. So if the patient is declared brain deaf, don't worry. Just answer the questions because they'll have questions. Vital signs, for instance, what medications the patient's been on. They'll take care about contacting the family. You don't have to do anything. Your role is just to provide honest information to live on. Okay. And then they'll contact the family, okay, about organ donation. Okay, you don't have to do it. That's not your role. They're good at it too. They know the right words to say to a grieving family. And usually, yeah, they get the organs. Pretty good. Yeah, they have a script, okay, to say what to say to a grieving family. Okay, I don't have much time. I don't want to continue beyond this. Okay, that's it for now.
I'm gonna read